So I guess we can start. We have a fully packed agenda for today's session, the Lunch and Learn in the project ACE. So you're all very welcome to this session. My name is Camilla Evanson. I work at RISE, Research Institutes of Sweden, and we are the lead partner of this amazing project ACE. Very welcome to today's session, and I see that people keep on entering, and that's fine, perfectly fine. This session is a Lunch and Learn session, and it's basically an invitation to several different stakeholders, both home care providers, innovators, and other stakeholders within the home care field. And the session is basically for learning from peers, getting to explore some practical experiences within this field, and also to take some insights when it comes to actionable insights from implementing technology in the home care setting. So I'm really happy to guide you through this session today. We will explore several different kinds of pilots that we have been conducting in this project. So let's see if we can skip to the next slide. So this is the agenda for today. I will give you a brief introduction to ACE and this session. Then we will have a look at really interesting key findings that we have found in a transnational survey conducted in all the partner countries from this project. You will also get to see some real-life pilot experiences from two of our pilots from Denmark and the Netherlands. Then we will have an interesting discussion at the end of this session with a panel. You're also going to be able to pop some questions in the chat to make sure that we can reflect upon them at the end of the session as well. First, some housekeeping rules. This meeting will be recorded, so please keep your camera off and mute your microphone. Thank you very much for that. And as I said, you're free to pop questions to individual speakers or to the whole panel in the chat during the whole session. And at the end, we will be able to lift some of the questions and reflect upon them at the end of this event. So now I will just give you a brief introduction to the project. ACE is an Interreg North Sea region program project, and we have been up and running for 3 years now. We're in the last final 7 months now, so we're ending the project in June. We're addressing the demographic challenge, and both the demographic challenge when it comes to the aging population and also the shortage in healthcare personnel. But we see this in ACE, that technology is one of the things that might be able to help us with this struggle. And this is one of the solutions to the challenge. So we have focused a lot on technology and digitalization in this project and piloted several different kinds of technologies in other countries. So we see the technology as one of the solutions to the challenge. What have we been doing in this project? We have been focusing a lot of the needs of the different care providers. That's the first thing that we have done. What is the actual needs? And we have actually managed to collect and decided upon 8 different needs in all of the countries. These are specific needs within the home care sector. And after that, we have been into a matching process where we actually have taken the needs from the care providers and the companies with solutions. They have been matched in a platform to see, can we pilot these existing solutions in the different countries and make sure that they might meet the needs of the care providers. So today we're actually piloting 22 different solutions in 5 countries in the North Sea region. And with the QR code, you're able to find our community platform where you of course are able to register and be part of this program and community together with us. And as of today, we also have launched a pilot website on our website. So here you can actually follow the different pilots that we're conducting in the different countries at the moment. So please enter that and have a look at the different pilots. Our ambition with the pilots is actually to have a company from one country testing in another country. So the transnational aspect has been one of our aims in the project, to make sure that we can support companies in bringing their solutions into other markets and be able to support the care providers in another country that might not have been exposed to that solution previously. And what are we aiming for in the project? The adaptations is something that we really try to collect during our pilots. In the pilots, we see how will we manage to implement these kinds of solutions at the end of the pilot. Something that has been really important is, of course, that the workflow might need to change. If I am going to be able to implement this technology, we might need to change our ways of working. We might need to include a physiotherapist. We might need to change some things when it comes to regulations or GDPR questions. So the adaptations is what really makes us mostly prepared to actually implement the technology after having conducted our pilots. Here you can see the 13 different partners that are included in our project, and we are in Sweden, Denmark, Germany, Netherlands, Belgium, and France. And these are the different partners. And as I said, RISE is the lead partner. So today, we are happy that you are here, and we would like to share with you the differences that we see between the countries. How is Homecare implemented in the different countries in the North Sea region? We also would like to bring you together to learn from each other and hopefully reduce the existing knowledge gaps between the countries. And we have conducted a questionnaire that Søren soon will talk about. And this will really highlight the differences that we see when it comes to how do we use technology today and how would we like to use technology? What kinds of, how does our workflow changes when we use technology, and how is it affected? So this is going to be really interesting to hear. So Søren, please go on with your presentation and share with us what the key findings are from the survey.
Yes, I'm Søren Orløkke from Aarhus Municipality in Denmark, and I've been in charge of performing an online survey with participants from all 5 countries. Originally, we wanted to have some events where we got people together from different countries, but in the end, it proved that there would be too many language barriers, and there was also a problem with people who work in home care wouldn't be able to find the time to participate in any event. So we actually decided to do it online. Yeah, the first thing I have to make a point of is that even though we are 5 countries that all work together for improving the home care situation in the North Sea region, there are very, very different models of home care in the countries that are involved in the project. In Denmark and Sweden, home care is provided by municipalities and funded through taxes. So, and the citizens can choose a private provider, but very few do, except maybe for cleaning. This means that municipalities typically are leading in implementing and funding new solutions and technologies for home care. In the Netherlands and Belgium, it's a more diverse situation. It involves municipalities, large private companies, non-profit organizations, and small private companies. The funding may come from taxation or from reimbursement via a compulsory private health insurance. And in France, the home care services are often hospital-based and publicly funded through national and regional taxes. I would say that from the point of view of citizens, when so many different organizations are involved and you're required to pay for a health insurance and get reimbursed, the more complex the system becomes for the citizen and not necessarily cheaper for the society. So this is some of the quantitative data, just to say, okay, we have from all 5 countries, a bit more from Denmark and Sweden than from the others, maybe because the respondents work in municipalities that have prioritized that they should actually respond. And it's about half of the respondents that come from that work in home care, that are care provider staff like nurses, physiotherapists, or care workers. Yeah, and if we look at the respondents, the main part, 60%, actually work in municipalities, and the same amount work in large organizations. So it's about 60% that work in an organization of more than 250 employees. And it's like just under 30% that work in smaller organizations with between 50 and 1 employee. So we actually wanted to ask care staff what their information level, what they knew about technologies for home care, what the impact of use of technology was in their work, and of course, which technologies they were using that they would benefit from or actually recommend. So we asked, do you know what technologies are available for your work? The red is all answers, and the blue are just from those that work directly in home care. And as you can see, the ones who say not at all, very little, or some knowledge are mostly care providers. Those who say very little or not at all are all care staff. And we also ask them, where do you get your information from? And quite interesting, the most common source, 80% of the answers stated that I get my information about new technology from colleagues through word of mouth, or for some organizations where they had staff specifically working with technology, or where they had digital consultants and that stuff. People would say, I get my new information from tech consultants in my organization. But it's clear that care staff generally know less about available technologies than respondents who work in administrative or consultancy roles. Maybe because frontline workers are busy with direct care, and they often become involved only during the implementation stage. This may highlight a need to better inform and involve care staff, both in the development and before and during the deployment of new technologies. So we also asked them, what impact does technology have on your work? And we get some interesting answers. So the first one is that most care staff can provide more care during a working day, and they spend less time in the old person's home. But even though that is the case, they don't feel that they have less professional responsibility than before. So 72% say that they don't have less professional responsibility. But the most interesting thing might be that actually 60% say that we do not provide less personal care than before. So this could imply that personal doesn't necessarily mean face-to-face or physical. Video solutions can be just as personal, even though they're used on a distance. We then asked them what technologies they were using that they would somehow feel had an added value in their work and that they benefited from using. So the first one is virtual visits and video calls. Those are systems where a tablet is in the citizen's home and care staff make video calls at scheduled hours, or systems where a camera is installed that enables care staff to look in at certain times to check that the citizen is okay. Some of the things they said about this technology is they highlighted that it promotes citizen independence and safety. It reduces the number of physical visits, which saves time and also saves transport, which means that it is actually saving resources. And also that it improves the flexibility for staff, which also goes for staff that can no longer manage the physical care work. So they might be able to work in the virtual video visit situation instead. The next technology that was highlighted was digital lock systems, which are fairly frequently used in Denmark and Sweden. So those are systems that make it possible to open a lock through an app and to grant staff access to specific homes. Here, it's highlighted that it makes it easier and safer for citizens who might be bedridden or have mobility impairments. It eliminates the handling of physical keys, which saves time and enhances efficiency. And it reduces administration and delays, improves coordination and documentation, because you can actually see who has accessed a home at a certain time. And the third technology, medicine dispensers, which are used in Denmark, Sweden, and the Netherlands, various products, but they're all technologies that can deliver various types of medicine at a given time, and to remind the elderly person to take the medicine and give an alarm if the person doesn't react. This promotes citizens' independence, it improves care quality and leads to fewer errors, and it reduces the number of visits and transport in a given care area. The last technology is also something that varies across the countries, but it's basically there are systems where a citizen can call for help at home or when they're outside in the city. And the care staff highlight that this enables citizens to live more active lives because they don't worry about maybe falling or whatever. It offers peace of mind for care staff and for relatives, and it promotes the independence of the citizen. And it improves safety and reduces response time for the people who are in charge of helping if something has happened. We believe that all these technologies should be propagated across the North Sea region because they are technologies that fit into any service provision system. They also promote an active and independent life with more safety from the elderly person's point of view, and they improve efficiency, reduce costs, and provide flexibility for staff from the point of view of the service provider.
Thank you very much, Søren, for the presentation. And we will have links to the report at the end of this session as well. And you are also able to pop questions in the chat if you have a specific question to Søren. And now we will introduce two of the pilots that have been conducted in the ACE project. And the first one is SARA, and Anouk Decat from Lika Lab in Belgium. She will present a few reflections after the video to you. She's working as a project manager and she's responsible for the pilot testing in ACE.
Met Lika Lab zijn wij partner in het ACE-project samen met Zweedse, Deense, Nederlandse, Duitse en Franse collega's. ACE draait om innovatieve oplossingen in de thuiszorg voor ouderen. We willen eigenlijk gaan kijken of oplossingen van die landen ook nuttig zijn voor de Vlaamse thuiszorgcontext. En we gaan nu onderzoeken of SARA daarin een meerwaarde kan zijn.
SARA is een Nederlands bedrijf. Wij ontwikkelen een hulpmiddel specifiek voor stressvermindering in de zorg. Dit kan door een activerend programmaatje of een rustgevend programmaatje af te spelen op maat van de gebruikers. SARA is plug-and-play, dus dat wil zeggen dat ze heel makkelijk in te stellen is op de behoeften van de bewoners. Het kan bijvoorbeeld snoezelen zijn om tot rust te komen, maar kan het bijvoorbeeld prikkelend zijn met quizjes, makkelijke vragenspelletjes, bewegen.
Ik vind SARA een hele mooie aanvulling op de zorg die we hier op de dagopvang al bieden. Omdat we met SARA heel mooi op maat gemaakte zorg kunnen aanbieden. Maar SARA kan er ook voor zorgen dat we de mensen meer kunnen motiveren om dingen mee te doen met ons. Door SARA kunnen we ook aandacht geven aan iedereen. Dat is wel iets waar we vaak tegenaan lopen op de dagopvang. En SARA is daar nu wel een heel handig hulpmiddel voor.
SARA is al jaren werkzaam in Nederland in de verpleeghuizen / woonzorgcentra's. En wij zijn nu aan het kijken met België om dat ook iets kunnen ontwikkelen voor in de thuissituatie. En vooral om te kijken van de effecten die we ervaren in de verpleeghuizen, werkt dat ook in de thuiszorg. Kan een mantelzorger ook meer rust ervaren doordat SARA dan met de gebruiker aan de slag is.
Great. Now I will hand over to you, Anouk. Please.
Yes. Hi, everyone. So yes, SARA is a Dutch solution tested in Belgium. And to give you some view on the methodology we used, this slide will tell you that. We did some demo sessions with informal caregivers. That was really interesting to also involve them. And we did a live test of 1 month in the daycare of older adults in Kalmthout. Then we also did a short demo session in Turnhout and a first test of SARA at a home of an older adult. Like they said, they also wanted to develop something in the homes of people. Yes, next slide. What we found were some learnings, necessary adaptations for the company. The company needs to adapt its market analysis and value proposition to the Flemish market. They should check whether the apps are fully compatible in Belgium, because that was sometimes a problem. And they should improve existing features and localize the content to regional culture. Even though we speak the same language, the culture is still a bit different, and it is nice that it's very close to what people know in Flanders. They can also add new features such as voice control. And they, like I said, they were looking at a new option for home care, but the current SARA robot is very costly and is not always practical. So maybe they can consider an app for existing devices like tablets of care professionals, that they can install on tablets of care professionals. And this way you can lower costs and ease the implementation of SARA. And also for policymakers, an important issue in Belgium is the funding for home care innovations. There is no or limited structural funding, so this is needed for successful implementation. Thank you.
Thank you very much, Anouk. And you're, of course, free to pop questions to Anouk in the chat if you have as well. Søren, are you able to share the video for HelpSoq, please?
Jeg hedder Kirsten Aabo, og jeg er leder af hjemme- og sygeplejen i Ålestrup. For præsteret en løsning fra HelpSoq. Det er en strømpepåtager, som vi har produceret i Holland. Det, der vil gøre det lettere for medarbejderne i hverdagen, er jo, at der er nogle borgere, som vi måske skulle servicere i dag, som egentlig selv kan lære at tage støttestrøm på. Så på sigt kan vi trække os som hjemme- og sygeplejen. På den måde kan vi også frigøre nogle ressourcer til nogle andre opgaver. Altså sådan et projekt er jo utroligt spændende at være med til at både at forme, men også at være med til at udvikle, fordi vi jo samtidig også skal vurdere, hvad er det godt i det her produkt, vi prøver af, hvad kan der udvikles på i det produkt, og det giver også en stor arbejdsglæde.
Jeg hedder Lene, og jeg er assistent herinde i hjemme- og sygeplejen i Ålestrup. Vi regner sådan set med, at der er nogen, der kan blive fuldstændig selvhjulpen ved den her HelpSoq. Jeg kan se den som en stor hjælp til både, jeg tror den giver mere kvalitet for den ældre, ved at de selv kan, når de står op om morgenen, tage deres strømper på. Og som APV tænker jeg også, at den vil være god, fordi der vil være den belastning på vores arme og skuldre. Jeg synes, det er spændende. Fordi at vi ved på sigt, at vi bliver mindre hænder til at servicere vores ældre borgere. Så jeg kan se, og jeg synes også, det giver en mere frihed for borgeren i sig selv, at de kan være uafhængige af os. Altså, de er mere frie.
Please guide us through your reflections and thoughts and insights from the pilot testing of HelpSoq.
Of course. Yeah, shortly, I just want to tell about the framework and the setup about the pilot test. As you see, the solution is to help the citizen to get on their compression stockings themselves or by help from the employees, the caregivers. We tested the solution in the Homecare district of Ålestrup, which is in Vestjylland municipality in Denmark, in the north of Denmark. And it was tested on 7 unique citizens. We used interviews with the citizen and employees to do our evaluation along with the business case analysis. And maybe I should say that we've already finished the evaluation and the pilot test. And some of the results are that we had a lot of defective HelpSoqs because some of the wheels broke. There could be a lot of reasons why it did. But despite that, both the employees and citizens expressed a desire to continue using the solution. And to these improvements, the company has made some significant improvements to HelpSoq based on these feedback from employees and also the citizens. And after these improvements, we have a need to do a pilot test number 2. So right now we are running it until the end of the year. and then we will see what we will do. But as I've heard, they are much better already. So yeah, it's a really big improvement. And some of the learnings and necessary adaptations we have seen is that the solution requires a very big knowledge from the employees and also an experience to handle the device or the HelpSoq, and also to train the citizen effectively. And it's also very important to establish a clear inclusion criteria because it requires the users to be very good cognitive functional. And there are also needs to be a greater focus on continuously follow up and on whether the citizen's functional level changes, especially if they get self-reliant, which a few of them has already been. Yeah, I think
Thank
that
you
was
very
it.
much. Thank you
Yeah,
very much,
you're
Kitty.
welcome.
And let's see if we get some questions at the end of the session to you. So now let's enter the next section of this Lunch and Learn events. Now I will introduce you to some of our colleagues in the project. They will be the panel representatives of today's discussion. We will make sure that we can discuss the barriers, but also the success factors when we have piloted these solutions and how we prepare to be as best prepared as we can in implementing these new technologies. So I am happy to introduce 5 panelists to you. You will meet Anouk. You have already met her briefly within the SARA video presentation. She's working in Belgium at Likalab, and she's the pilot coordinator for ACE there. She's used to and have experiences in working with healthcare innovation and design thinking, and they also have a living lab approach at Likalab. You will also meet Tessa Dirks. She's working in the Netherlands for Care Innovation Center. She's also one of our pilot coordinators from the Netherlands, and she has experience in collaborating with local care organizations. You will meet Lord Simba from France. She's working at our partner company Cowork and HIT. She has experience in biomechanical modeling, risk management, and clinical evaluation, for example. And let's continue with Martin Hagman. He's working at Höganäs municipality in Sweden. He's specialized in digital and data-driven development and digital transformation. You will also meet Magnus Kinley Mogensen, also from Denmark, Aarhus municipality. He has experience in working with the rehabilitation for people and testing and developing technology-based solutions. And all these 5 persons are working concrete with our ACE pilots in the different countries. So they are well experienced in how things have been doing, how we have conducted the pilots, and all the adaptations and changes that we have collected that might need to change in order to be best prepared for successful implementation. So we will start with the first question. And the question is, can technology completely solve the staffing shortage in healthcare? And I will ask you first, Magnus. Can you please elaborate a bit on this question from your perspective?
Of course, and I would say absolutely not. But technology is here to help us. Because I think technology only makes sense when it's introduced properly. And implementing new technology simply takes time, and we need the active involvement of a healthcare person from practice to give them our insights and inputs to the solution. And as it was mentioned earlier by Søren, people from practice are running as fast as they can. There's already a staffing shortage, and then us as implementation consultants are on the side, also asking for their time because we need them as part of the process of implementing technology. And we need this to maybe get technologies that in 3, 4, 5 years, we start to see the benefits of these technologies. So that's why it's important for management also to support our work and the introduction and implementation. Because we need to stay ahead of time and maybe we should have been doing it so for 5 or 10 years. Yeah.
So is anyone else from the panel ready to jump into the discussion? Martin raises his hand. Please, Martin.
Yes, I think Magnus is right on many points in his answer. I think technology is crucial, and it will help us to solve the staffing shortage. But it's not only technology as an isolated item for the solution. We need to change the ways of working, and of course, including our staff to plan that in the right way. Technology is not a replacement for the staffing shortage, but it's a complement. And the good thing about this ACE project that I really want to highlight is when we start mapping out the needs that we need to satisfy for our citizens, then we also can provide the right solution, whether it's technological or some kind of other solution, organizational or planning tools in any way. That's my point on this subject.
Thank you, Martin. Some reflections from the other panelists, please.
Yes, I think a lot is already said, and I totally agree with Martin and Magnus about that it can help in solving part of the problem, but it's not the solution in itself. So I think we need to work differently and work smart and let technology help us with that.
Laura?
Yeah, I agree with the partners, and I would say that technologies can ease the pressure of care professionals, but it cannot completely solve the staffing shortage. And one of the examples that we can give is that most home care technologies today generate alerts and monitoring data and follow-up tasks. And these tasks require human attention because a care professional has to review and prioritize and act on the information that are received. So, yeah, this requires a human attention. And also, we saw that citizens value human interaction and reassurance and relational care. So technology can support professionals and optimize time and improve safety, but it will never replace the human connection that is central to care.
Thank you, Laura. Anouk, do you have some reflections from your perspective as well?
Yes, I agree as well. So yeah, technology can ease the healthcare staffing shortage, and it can support them by, for example, automating administrative tasks. And like that, more time would be available for in-person care. We still need to invest in job attractiveness. That's still essential to have enough people in healthcare.
A short reflection from my side is from the HelpSoq video. I mean, here we can see an example of technology being used out in the homes of the older adults, which frees up time for the staff. They don't need to drive with their cars half an hour there and half an hour back to help citizens. So they have freed up time to be sure that they can actually use that to personal care face to face instead of sitting in a car driving back and forth. So then we will jump into the next question. And that is, does every innovation fail without active involvement of end user and testing in real environment? And I will ask you first, Laura. Please give your reflections from your perspective and experience.
Yeah, from my perspective and experience, I would say yes, or at least the risk of failure becomes very high without involving end users. I think they have to be involved early in the process, whether they are care professionals or citizens, because involving them would save money and time for companies, because the solution will be aligned with real needs from the start. And it also increases acceptability and future adoption. When users feel listened to and see that their feedback are integrated, they are much more likely to engage with the solution. So,
Magnus, thank you, Laura. Magnus, please.
Yeah, I agree with Laura. I don't like to be definitive, but yes, I agree. But not just the end users. I think it also needs to be context specific, because even though Denmark is quite a small country, at least, but from municipality to municipality, there can be huge variabilities of which technologies that actually work, because the context and the organizations might be different. So the technology is the same, nothing is changed, but 50 kilometers down south, it works perfectly because there's a contact person, there's one who's really creating this initiative. Whereas if you go 50 kilometers north, the same technology may not have the same effect. And that's why you need to be very specific when introducing new technologies, looking into which contexts and which persons are there to implement it.
Yes, I agree with that. And I also was thinking sometimes a bold move is needed to disrupt the system we're living in nowadays. So then sometimes the involvement can hold it back a bit, but I think in the end, always end users are always needed to make it work. But sometimes to disrupt things, it may be better to have someone thinking out of the box and then involve the end users.
Yes, my answer to the question is no, because I wanted to be a bit opposite for fun. No, I really have thought it through a little bit anyway. I think in most innovations there is a very good with the end user involvement. But I think, and I think especially of a pilot that we're doing in Höganäs, where we are processing a lot of data that hopefully will come to benefit for the citizens in the end. But it's actually a tool for maybe a physiotherapist to make their work easier in identifying patients that with high risk of falling, for example. And then we haven't really included the end user in any way yet, but we're still developing and trying out new things. So it's a matter of how you approach the question about innovation, really.
Okay, I will say the opposite. I say yes. This is really what we do as a living lab, involving end users in the development of innovations. And I really think you should base your developments on the needs of those people. And by the people, I mean healthcare professionals, older adults, but also all the other home care stakeholders. Try to involve them as soon as possible and as continuously as possible. And this is the way to go to increase the chances that innovations will be adopted in practice, I think.
Thank you, Anouk. You're addressing something that we have been discussing that a lot in the project regarding what is end users and how many layers of stakeholders needs to be involved inside the organization and outside in order for us to prepare for a successful implementation, because several organizations usually state that they are sick and tired of just testing and piloting, and it stops and ends after the test. We need to be prepared and try to build knowledge to be able to do it successfully after the testing process as well. And then the stakeholder question and the end users, who needs to be involved from start. So it's an interesting discussion. So let's enter the third question. What barriers do care organizations experience when testing technologies? And in this question, I will start with you, Martin, please.
I will give an example that we had in one of our pilots. I already mentioned the AI solution. And we have experienced quite a challenge when preparing this pilot, because of there were a lot of legal issues about information security and GDPR in combination with the AI solution. So we really needed to penetrate those issues with help from legal competence, both locally but also on a national level. So in the end, there was a very thorough work from one of our local lawyers that led to a principal decision really from our head of municipality and head of social services in our municipality. Could we dare go further with this solution based on the work from our legal staff? That was a question we had to ask, and Höganäs chose to go through with it. And I think it needs to be a lot of bold decisions in those fields, because nobody really knows how to do it. So for us, it was a great barrier, but we also managed to work through it. So we're doing the pilot now, anyway.
Thank you for sharing, Martin. Laure, please.
Yes, I agree with Martin, because when we experienced the pilot for the ACE project, we saw that some technologies, as Martin says, as software, apps, or connected systems, are really more difficult to test regarding the GDPR and data security requirements. And here in France, we see that these solutions need to be connected to the care organizations network, and which raises cybersecurity concerns. So one potential solution that appear actually in France is to create specific network for care organizations dedicated to testing. But most of the care organizations today do not invest in such tools. And I would say here that one of the main barriers is time, because care professionals are overloaded with clinical tasks, and they have very limited availability to participate in testing. And also on the company side, some providers cannot easily lend or give access to several devices without a purchase commitment for testing. But care organizations have limited financial resources so it's difficult for them to free up staff time to do the test, and also invest in solutions before they have been testing it. So, yes.
Thank you, Laure. Magnus, please.
Yeah, I would like to continue on Laura's note on staffing shortage, because I think that's also one of the big barriers, is that there's already ongoing initiatives and projects in Aarhus municipality. And so it can be difficult to again come with a new solution again, because there is a shortage. So they only have so much time to test new technologies, and we can't take that much time. And I know also in Aarhus we are doing a revitalization of existing technologies, because that's also a major concern, is that you introduce technologies, but then after 3-4 years, staff members or care staff actually forget to use the technology, and then we need to revitalize it again. So that's also an initiative that's going on while you try to bring new technology into the setting as well. And in Aarhus, it's also a very centralized organization where management, they want to be able to collect data and experience from each projects and see how it creates value and if it makes sense, and whether or not it should be pushed to the entire municipality. And that makes sense. But this way of thinking also makes tests suddenly very big and very time consuming. So it's difficult for Aarhus to create these short sprints where we test technologies, because they wanted to have like it's getting big from the beginning. Yeah.
And to add on that, Magnus, we have seen in the project that there are huge differences between larger and smaller municipalities. Obviously, we have Höganäs and Väst-Himmerland, Höganäs in Sweden and Väst-Himmerland in Denmark. They're quite small municipalities. And we have Aarhus, as you say, Magnus, in Denmark. It's quite a huge municipality. And there are obviously differences in between them. So Tessa or Anouk, would you like to add something to the conversation?
Yeah, I was thinking about the Netherlands. Partly it's already discussed, like time is also an issue we see a lot of the times popping up. But also what I was thinking about, like sometimes it's really person specific if you can do a pilot. So if you have a person that's really enthusiastic about a product, then they are able to free up some time or spend time for themselves to test the product. But if you can't find that person, you also have like those teams, innovation teams in like the bigger organizations in the Netherlands, and they are really working. We're working together with them a lot, but they also are sometimes the gatekeeper of the organization about what's going to be a pilot or not. So it's working both ways in that case. So yeah, I think time is mostly the barrier we hear in this case, and also what you can see in some organizations, some home care organizations, they are already saying, okay, 80% of our time we can spend on innovations. We spend then on proven innovations, so not on piloting new products, but only the products they want to implement, they already know it's going to work. Yes, I agree with Tessa. If you can show the added value to professionals, you get them on board. But as a barrier, I can give maybe one example. I agree with all the other partners on the barriers. In a pilot, we came across financial constraints. Even if the pilot, during the pilot, the company provides the solution for free, they still want to know, okay, what does this solution cost, and can we implement it after the test? So they didn't want to test because the solution was too expensive. Nonetheless, the pilot itself was for free. So yes, as a barrier, I would like to say financial constraints again.
Magnus?
Yeah, I was just I was reminded of what Tessa said, that there's this joke that when looking for a job, you want a 20-year-old with 20 years of work experience. And I think it's important that when municipalities only want technologies that are validated and tested in other municipalities, they also need to think...
We will never get started.
Yeah, exactly. We will never get any further. So someone needs to be actually help the companies. Yeah.
And as we know, Martin, you explained about your challenges with the AI model and GDPR. You're one of the first going in the front, really exploring and taking that bold decision, as you mentioned earlier. So, Martin, please.
Yes, I just heard Anouk. I think you talked about added value and to prove that somehow. I think that's not enough. In change management, there's this mentioned like sense of urgency. It's you have to stretch it to that for making the care providers really interested. And then sometimes sense of urgency plays out the economics of it, because when you realize you really have to do something, then you have a lot of more will and to work through it. Yeah, that was my point.
And to add on that discussion, as I told you briefly about earlier, the first year of this project, we actually digged really deep into the needs and the challenges and what were the most pressing needs that had a really high sense of urgency in all the 6 countries in our project. And that was basically the foundation that we have built the tests on after, because as you all mentioned now, it's really important to have that sense of urgency to be able to jump into it and really try on and test. And so I think that's really important as well. So now we will jump into the next question. What do you think that companies should consider when entering new markets and testing new technologies? So I will start with you, Anouk, please.
Yes, from one of the ACE pilots, we noticed that the company entering a new country, Belgium in this case, they may discover that their technology is less mature in this new context than they would have thought. So this would require extra fine-tuning, and that's why it's very important to have a strong team ready to solve these technical issues. They should be open to feedback, eager to learn, and be flexible. Understanding the new care context and being willing to adapt the solution to the specific needs of the Belgian target group also increases the chances of a successful test and implementation later on, hopefully.
Yeah, I want to pop in on what Anouk said, because what I also noted with the ACE pilots and having the conversations with the companies and the care organizations together. And what you see is that like some companies, they are really open to listen to the care organizations, to be flexible, to adjust their product to the new context. And you see that that is working really well, but sometimes the companies are so keen on their own product that they don't really listen to the other person sitting in front of them. And then you see the conversation is not going anywhere, and you don't have like the basic trust level between the company and the care organization. So I think it's really important for the companies to be really listening to what the other person is saying, the other organizations are saying.
Yeah, I would like to react to what Anouk and Tessa said. And sometimes to understand the context, the specific context of a new country, of a new market, it's easier to start with small pilots before doing big studies to understand the specific needs of the new market. And yeah, another point in France, which is really important here, it's that companies also need to understand how the solution could be funded or reimbursed in the specific country. For example, in France, this may involve the social security reimbursement, but also support from MDA, which are local autonomy support centers, or other public funding schemes, because financial resources are often limited for the care organizations and also for the end users. So without a clear reimbursement pathway, even real promising innovations are difficult to adopt. So companies really have to understand the local care pathways and these financial aspects.
Martin, Magnus, do you have some reflections? Magnus first.
Yeah, I want to add on the flexibility of the companies. In one of the pilots here in Aarhus, we had a great product with a lot of options, a lot of functionalities, AI. It was really interesting and really great. But when some of the healthcare staff were looking at the solution, the need could maybe be assessed in a much simpler way. So is there actually a need for all these complex functionalities? Because when they are introduced, the implementation process also gets a lot more difficult, because we have it's already been said, data processor agreement and such. But if we can actually simplify the solution, so our companies, do they want to do that? Or do they just want to sell the product that they have? So do they want to go into a collaboration together?
I think Anouk and Tessa, you're working with the companies more closely, and I think I'm glad to hear that they are so willing to listen to our needs and adjust their products for the market. That's really good to hear. But I think making solutions work together with each other is a crucial thing. I think this is a huge one. Interoperability between systems will be a great issue in the future. The responsibility is very much on the companies providing solutions, but it's also in the procurement and how we design our demands when we procure solutions from the business. Yeah, that's my point of view.
Thank you very much, Martin. Now we will jump into the last question of this panel discussion, and then we head a bit looking at the future. So what will home care look like in 2030, according to you in the panel? And I will start with you, Tessa. Please bring in your perspectives and reflections on this question.
I hope in 2030, home care will look like that the persons living at home are more supported to live their life themselves without depending on the home care staff to come by, and the home care staff that they are more supported with the technology. And what Martin mentioned before, I think the interoperability part is already an issue now and not only in the future. But I think it would be nice to develop, like, if there are technology solutions, like digital solutions, that part will be solved or will be made easier at least. Yeah.
Anyone else want to jump into the future looking? Martin, please.
Yes, I think it's probably a bit the same as Tessa, but I think we need to include more technology, innovation to survive as caregivers and to provide the right help with the right solution for our citizens. But I also think in 2030 there will be a much more digitally mature citizens, and there will be easier for us to implement those kind of solutions because it's really what they want. And I think it's not the issue today because it's a generational question really. So I think and I hope there will be a much larger digital maturity in our society, and that will make our work easier.
Thank you, Martin. Magnus, please.
Yeah, I think 2030 is dangerously close to where we are right now. It's only 4 years away. So I'm not trying to be negative, but I think it will look the same as it is today. But hopefully, I also agree that we will have more sensors. And as Søren showed, telecommunication is very great and positive, and the healthcare person thinks it's positive. So I hope we will have more of that. And then maybe there's also a large private market for digital healthcare technologies. So maybe these can be incorporated in a municipality system. So when people buy a digital product on themselves, a municipality can actually be able to take some of these informations and react upon them. And then I hope Homecare will have a larger focus on health promotion and prevention of disease.
I really like your realistic point of view, Magnus. My answer really sounds a bit more like a early Christmas wish. So I would like by 2030 that Belgian Homecare will use technology to create more space for warm, human-centered care, where both caregivers and older adults feel valued, supported, and genuinely rewarded by the care experience.
Thank you, Anouk. Sounds really like a really wonderful Christmas gift. Laura, please.
I will continue with the Christmas gift. So, yeah, I agree with Magnus. I think digital tools should have a big part of home care to support earlier detection of risks, so prevention, and also to be able to have a smoother coordination between care professionals and maybe more personalized care plans. I wish that citizens will have more autonomy thanks to simple and well-designed technologies that fit naturally into their daily life. And we could imagine and hope that people could also have access to a wider range of living options, from staying at home to shared or intergenerational housings, and allowing each person to choose the environment that best fits their needs and preferences. So yeah, a big wish list.
Thank you, Laura, and thank you, everyone. And it feels really great to be able to work in this project. Over 6 countries, we have identified the same challenges and needs that we're working with, and we're all moving in the same direction. And that's basically towards our joint Christmas gift then. So it feels really great to be able to do this work together. It makes us stronger, and hopefully it makes more impact. That's at least our ambition. Thank you very much, panel, for this discussion. And now we will jump into the questions and reflections from the audience. Søren, could you please guide us through some selected questions?
Yes. The first one comes from Gaia Langerfeld, who was the first one to raise her hand. And she says, were the evaluations business cases made with similar methods across the countries? And are there Are they or were they aligned with the requirements of the different national reimbursement systems? I don't know if one of the panel members could perhaps answer.
Well, if I can just start a bit, I'm not really sure that I understood. If I understood the question right, obviously in this project, we have made some joint guidelines that we have followed during the whole implementation of the different pilots. So we have, for example, developed a tool, a pilot testing tool that everyone has followed the same, to make sure that we are able to do it as in the same way in all the countries as possible, because this also makes it possible for us to do the comparing and knowledge change between the different countries. We have also made sure that we gather all the adaptations that we have found from the pilots that really needs to happen in order for us to implement this specific technology after the test. So that is just the basic information that we have formed joint tools and guidelines to conduct the pilots. Does someone else want to jump into the discussion as well and reflect upon the question?
Yeah, I can do. I can answer because in the pilot process tool that you mentioned, there's also included space for your own local needs, so to speak. There is guidance, but then it's also suggested sometimes in the tool that you might want to use the national or local documentation instead. So there is a suggestion for personal data. What's it called? Personal data processor agreement, but it haven't been used at all, I think, because you need to design it from national point of view. That's just one example.
Otherwise, we can take the next question then, Søren.
The next question would be, how would the path forward look for companies operating in preventative technologies being adopted in home care? Basically, what should they do to be adopted in home care?
I think part of it is maybe answered in like the question about the companies. But for preventive technologies, I think still like do a small test and get a conversation with all the stakeholders and see their perspective and move on from that forward, I think would be a good step to see what's really needed for that technology. I think it really depends on what the technology is and how the way forward looks like.
Martin?
Yes, I don't think we've mentioned TRL before today, technical readiness level. In the ACE project, we want to, the companies need to be on level 7 out of 9 to be able to participate. So the companies need to study on how to reach a higher TRL level regarding the national, regarding the country that they are wanting to approach with their product. So I think that's what ACE really is helping the companies with. But in the future, maybe there will be some kind of guidance on the European level because we've made much good work in this project, and that can be used further on. But that's a challenge for the companies to take on.
Magnus?
Yeah. I would say it's also a societal thing, and now I'm talking from a Danish perspective. I know preventive solutions and technologies are getting more and more focus. In my opinion, they could have a lot more focus, but at least it's getting better. But sometimes it's also a difficult task for preventive technologies because the economy and the savings are not right now. They are in 5 or 10 years. So it's a difficult business case for them. But I would say, just as Tessa mentioned, keep validating your product, keep making research about your product, so you actually can show something to municipalities and public institutions that yes, by using our solution, you actually save ABC. Yeah.
And to add on that discussion regarding prevention, I think we have touched upon it several times today. You, Magnus, earlier, wishing for that for the future, obviously. And when speaking to you, Martin, and the Höganäs team, and when we take a look at the sense of urgency once again, I think that the sense of urgency in the different municipalities and among care providers makes it more needed to have a look into the preventative aspect as well, to make sure that you really try to push things to the individual, trying to help them and support them to be independent, making things on their own, and in this way you relieve some of the care staff and push that demand into the future instead. So I think the preventative aspect is also part of that sense of urgency, that you really see that you need to do things at the moment. So let's see, let's jump into the next question. Søren, do we have some more questions from the audience?
There are a few comments. One from Gaia Langerfeldt again, regarding the importance of continuous and structured engagement of end users, primary, secondary, and tertiary. I would like to refer to the AAL legacy, an analysis of over 16 years of innovation in the active and assisted living program. This stresses it is one of the cornerstones for success. So that's the continuous engagement of end users. Then I have a comment from Martin Habby. He says, today there is a shortage of staff. Everyone who works has a lot to do. How are we as a supplier then to get municipalities to test and evaluate a new service that can save time? They have neither the time nor the money to prioritize tests, even if it means that they will soon not be able to complete their mission. Yeah.
Anouk,
that's
please.
the
Anouk.
dilemma.
Yes, I would say to involve organizations of that country who have like a good network of care organizations or municipalities. For us, we are a living lab, so this is what we do. We can make the bridge between you and a care organization, and there are still some pioneers out there who really love to test innovation. So yeah, I should suggest to go there.
There's another comment here that we have also reflected about in the project. It's from Kartik Srinivasan. He says the main concern here is how would you advise companies who are operating in preventive space? They feel like they're operating in a space between regions and municipalities. For example, fall prevention is extremely key, but then the biggest winners is regions and hospitals, since the cost of hip fractures are enormous. But then the care for elderly itself is in the municipality side.
Yeah, that's basically something, especially in Sweden and Denmark, I suppose, that the older adult is the person that brings both the region with the hospital care and the municipality with the elderly care together. That's the joint touch points, and obviously that's a challenge. Who is going to pay for the services, and who gets the benefits from implementing it? Do you have any reflections from the panel?
Yes, I think it's expensive with the hospital care, but it creates a lot of work for the home care as well for a long time forward. So I mean, the cost of a hip fracture is almost not foreseeable, really, because we don't know what kind of help they would need if they didn't have the fracture, but we really know it when they have had their fractures, because then they are in our care, and that's also a very economic question, but it's also a great question of suffering, and if we can prevent falling in their homes, they can stay healthier for a longer time, and they won't need our help that much. So the economics is also there, I think.
Thank you for sharing, Martin. And the last reflection from you, Magnus, then we need to wrap up this Lunch and Learn event.
Yeah, it was just how to come in contact with municipalities. I can say for Aarhus municipality, we have like a shared entrance for all companies that want to collaborate with us. So every company that wants to do something, they go and fill out this form, and then they are evaluated by some people in the organization, and we have this database over each company. So that's one way to do it. And as Anouk said, keep looking for contacts. That's always a great entrance. You can get ahead of other. So stay in networks, stay updated. Yeah, there's no easy, there's no good answer, I'm afraid.
So thank you very much for all your questions, and thank you to the panel for bringing all your experiences and expertise from our pilot work in ACE. So now it's time to wrap up this Lunch and Learn event, and I will conclude the meeting by saying that we will have a final event in Antwerp in Belgium on the 20th of May next year. This will be the time where we will invite all different kinds of stakeholders. We will make sure that we will present our strategy for the future and an actionable plan for operational work and hands-on how you could relate to all the adaptations and every knowledge that we have learned during this project. So you will, of course, get an invitation to this event. We will also like to kindly ask you if you are able to fill in a form. We will send this by email after this session has closed. We will also attach the recording, of course, with the seminar and the report that Søren has been talking about. But this is basically one of the KPIs that we need to fulfill. And this is basically you telling us your organization's name, your VAT number, and then ticking a box that you have undergone a learning process. For example, this kind of event that you have been participating in today, or taking part of a newsletter. So this is basically to make sure that we increase all participants' skills and knowledge within this field. So kindly asking you to fill it in when receiving it. You will also have a link to our webpage where you can find the report that Søren has been talking about. You're also able to download it from this QR code. And by this, I thank you very much for participating in this Lunch and Learn event. I hope that you have all received really good insights, actionable insights, and that you've learned a lot from the different countries and their experiences in piloting different kinds of solutions in the home care sector. So thank you very much. Please feel free to get in touch with us after the seminar. Look forward to hearing from you. Have a nice weekend and take care, everyone. Bye bye.